Okay, good evening. Good evening. Welcome to the perinatal medicine session, Bridging Fetal and Neonatal Care. We're going to go ahead and begin the session. The first speaker will be Dr. Carlos Guinea. Professor Guinea is from Hospital Vall d'Hebron in Barcelona, and he will be discussing fetal tumors, the perinatal approach. Welcome, Dr. Guinea.
Thank you, Ayman. Hello, everybody. Good afternoon. I want to thank the organizations, Professor Sharif, for having me here. It's a privilege, as usual. Okay, so we are going to discuss what we can do about those patients with those fetuses with some tumors. As you know, fetal tumors are quite rare. But the true prevalence may be higher because we have the stillbirth and the legal interruption in Europe. And it's because of a failure of cell differentiation of maturation during embryonic or fetal life. So we have to diagnose them, know very well the natural history to reach a proper counseling. And the prenatal intervention normally in those cases is just a life-saving procedure because the treatment of the disease, of the tumor, normally it's going to be after birth. So there are some tumors that we can offer something perinatally. Not all the tumors, unfortunately. So we are going to speak a bit of those tumors that compress the airway, the thoracic masses, pericardial teratoma, sacrococcygeal teratoma, etc. So regarding the airway obstruction, if we do nothing, we have a high mortality when the airway is compromised. So there are neck masses and oral masses and multiple causes, but by far the most frequent are the teratomas or the lymphangiomas. So in both cases, we have an occlusion or a compression of the airway and the digestive tract as well, the esophagus, and we can have polyhydramnios. In any way, the airway control is jeopardized. So what can we offer? We can observe them if the compression is not too big. We can punction the cysts when we have cysts to decompress, to release a little bit the airway. We can do interventions under exit procedure to secure the airway. Or we can just do that after the C-section, which is quite risky because we have little time to act on the airway of the baby. So interventions on the airway is doing nothing if the baby has no problem. Again, needle decompression of the cyst, direct laryngoscopy and intubation, which is very frequent. In some cases, we need to do a tracheostomy, or in some other cases, we have to excise the mass to allow the control of the airway. So the important questions we must ask ourselves is which patients will require an exit procedure for airway control, and which patients may require an airway intervention, and when is the best moment to do that. So we have many radiological indicators of compression of compromise of the airway, but the anatomical compression by far it has a significant correlation with the need of exit. And when we have solid masses and polyhydramnios, we have a high chance to have to do something into the airway. So in this case, this is a teratoma, an oral teratoma, and the neck is free, so we can, under exit, perform a comfortable tracheostomy, take the patient next door afterwards, and take the mass out. This is another case of a teratoma, a neck teratoma, which is quite solid, and it was difficult to intubate, and we need to do under exit procedure, the release of the airway by moving a little bit the mass. So we could intubate, and then we take the baby next door to finish the intervention. Lymphangiomas are quite easier because normally you can punction a large lymphangioma to release the compression, and they are softer. So normally under exit procedure we can intubate them more often, like in these two cases. So which patients require an exit? Those patients with airway compression or suspected airway compression, big masses, and patients that we think that will require an airway intervention, which are solid masses, polyhydramnios, and airway compression. When to perform that? Hopefully, the later the better, no? Beyond the 34 weeks of gestation, if it's possible. Regarding the thoracic masses, they act as a mass effect, compressing the lung, so we have a pulmonary hypoplasia, compress the esophagus, so we have a polyhydramnios, and compress the mediastinum, and we have a decreased venous return and hydrops fetalis. So we can divide them in congenital malformations, like the CPAM, or congenital pulmonary airway malformation, of course, bronchopulmonary sequestration, bronchial atresia, and congenital lobar emphysema as well. But we have as well two tumors. Are very rare, but we have them as well. So for the CPAM, we use the old Stoker classification for prenatal for fetuses in 3 types, depending on the size of the cyst. The prenatal course depends on the gestational age, the size of the mass, the amount of mediastinal shift, and the fetal hemodynamics. Normally they grow until the week 26, 28, and after that they remain still normally, and only one third of the patients will generate an hydrops and will need some action. And the prognostic indicators, we have many of them. The most important one is the CVR, that when it's beyond the 1.6, as you know, the risk for hydrops is very high. But in contrast, when it's low or we have no hydrops, the survival rate of these patients is very, very good. So in case of hydrops or pre-hydrops situation, we have to go for fetal surgery. We have 3 lines: corticosteroids, which is particularly interesting in microcystic CPAM, shunting the cyst or the hydrothorax in case that we have it, or surgical resection. What we have to do, what we do when the baby is very young, before the 34 weeks of gestation, we can reduce the volume of the mass with corticosteroids. We can place a shunt if we have a hydrothorax on a big cyst, or if it fails, we are forced to go for open fetal surgery to resect the mass. So when it's beyond 34 weeks of gestation, if it's possible, an early delivery in postnatal surgical resection is what we are looking for, but sometimes we cannot assure the oxygenation of the patient, and we take advantage of the exit procedure and the maternal-fetal circulations to take the lobe out, like in this case. So about bronchopulmonary sequestration, they don't usually need a prenatal intervention. It's very seldom. Because they decrease during pregnancy, they associate with almost nothing, and they have a very good prognosis. But still, there are some rare cases that may deal with pleural effusion, polyhydramnios, and eye drops. And we can do the same, and some groups have tried the laser ablation of the feeding vessel with several outcomes. So for the bronchial atresia, again, it's an complete airway obstruction. We have central or peripheral, and if it's peripheral, we have a lobar overinflation, bronchocell, hyperlucent lungs. When it's central, normally it's lethal, like in this case, but there are some groups that have attempted successfully the fetal tracheobronchial endoscopy with laser ablation of the atresia to recanalize the airway. So when it's peripheral, normally we take postnatal care because normally there's no problem in utero. A congenital lobar emphysema is the same spectrum of the malformation, and sometimes they have the problem when they start to breathe because the lung starts to overinflate, and sometimes we have to operate on them in the first days of life. Regarding the 2 tumors, they are very rare. They are an imagery very similar to congenital pulmonary malformations. They are very difficult to distinguish sometimes. But when we have to suspect them when we have a rapid development in the mid and 3rd trimester. They rarely need prenatal treatment, and if they do, we do the same as a CPAM. Pericardial teratoma is very, very rare. It's only about 12% in some series of the cardiac tumors. They have a rapid growth and they compress, of course, the heart and the major thoracic vessels, leading to hydrox. So we have those alternatives perinatally, the pericardiocentesis, pericardiomniotic shunt, thoracoamniotic shunt if we have a pleural effusion, or open fetal surgery or exit to resection. There are few cases reported in literature with 3 open fetal resections and 1 exit to resection. This is a pericardiocentesis, it's one of our cases last year. Sacrococcygeal teratoma, I'm going to be quick in here because Dr. Ayman is going to talk about that later on. It's the most common, teratoma is the most common tumor in the neonatal tumor, and 60% of those are sacrococcygeal. Normally they are benign, they are associated, they are not associated to other entities, affects the 3 germinal lines. We have 4 types of sacrococcygeal teratoma. And it's a spectrum from solid to cystic. So they have a rapid growth and vascular proliferation, which is greater in solid tumors. And that means that there's a low vascular resistance within the tumor, a vascular overflow shunt effect to the tumor, and hyperdynamic circulation with an increased cardiac output with that can lead to heart failure, like a cardiomegaly, valve regurgitation, a reverse end-diastolic flow, dilated inferior vena cava, and that can lead to polyuria, polyhydramnios, and placentomegaly, and hydrops fetalis. These are the cases that we take care prenatally. And the prognostic factors depends on the morphology of the tumor, the size of the tumor, and we have some indexes for that, growth rate, and signs of heart failure. So the criteria for fetal interventions are solid tumors, the size of the tumor, the evidence of fetal cardiac compromise, and the absence of other major associations. So this algorithm, I like it very much. If we don't have adverse prognostic indications, we just do a weekly evaluation. But if we do have adverse prognostic indications and the baby is viable, we go for a fetal intervention. If it's viable, we go for emergency cesarean section. The open fetal surgery mainly is the tumor debulking, which has a reported survival rate nearly 60%, which is very good. There are some other alternatives, very seldom used, the endoscopic laser ablation of the superficial vessels or the intratumor injection of alcohol, very few cases in the literature with a survival rate around 20%. Intratumor laser ablation, we have 14 patients in the literature with a survival rate of 50%, and intratumor radiofrequency ablation, it's 12 patients in the literature with a survival rate of 67%. We don't do that, so we don't know much. And we have some other tumors like intracardiac tumors, mainly rhabdomyomas, tumors of hepatic origin, tumor of renal masses like particularly the congenital mesoblastic nephroma, and adrenal masses like neuroblastoma. Unfortunately, we don't have options for those very patients. And we have as well the ovarian cyst, and I'm not going to talk about that because again, we have a wonderful lecture afterwards that will deal with the situation. Thank you very much for your kind attention.
Thank you, Professor Carlos. Thank you. And then now that our next speaker is Professor Ayman Shaaban. He's going to talk about prenatal and postnatal management of diseases associated with high cardiac output failure in the fetus teratoma and the TRAP sequence.
Okay, thank you very much. This is a little bit repetitive here, but we'll go a little bit deeper into the evaluation prenatally of sacrococcygeal teratoma. So before we had spina bifida surgery and other surgeries, we operated primarily for life and death situations in the fetus, cardiovascular physiology and cardiovascular collapse. There are 3 types that we generally, as we group them, situations of high output cardiac failure, low output cardiac failure, and complex cardiomyopathy, as in twin-twin transfusion. Today I'm going to talk about a little bit about high cardiac output failure in 2 situations, sacrococcygeal teratoma and twin reversed arterial perfusion sequence. As you saw before in the previous presentation, the incidence of sacrococcygeal teratoma is quite rare. It has a very interesting high ratio of female to male predominance. some associated anomalies, but usually the karyotype is normal. There can be a malignancy, but the majority are benign. Again, this is another review of the Stocker classification system. The type 1, which is predominantly exophytic on the outside. You can see how large this is, and you can also appreciate the very large vessel here, the feeding vessel, an extension from the presacral vessels. And then the type 4 on the other side here, which is predominantly intra-abdominal and intrapelvic without an exophytic portion. You can see how this very large tumor here pushing the bowel all the way up to the diaphragm. And the type 2 and the type 3 variations of mostly on the outside, mostly on the inside. The pathophysiology for high cardiac output failure in the fetus with sacrococcygeal teratoma is described here. You can see the vascular steal is the primary problem. The vessels supplying the tumor here, you can see this tumor and the spine on the sagittal view here. The vessels supplying these tumors can be very large, as big as the aorta very frequently. And as a result, they start to increase the amount of cardiac output and the amount of preload that exists. But the fetal heart is different than the adult heart. In the adult heart, as the pressure increases, the stroke volume increases in the adult heart. The fetal heart, however, as the pressure increases, the stroke volume does not increase. And as a result, it leads to concentric hypertrophy of the heart, as you can see here. And over time, you see the signs of high output heart failure, high drops, placentalomegaly. Eventually, it can progress to maternal mirror syndrome, and then mortality and morbidity of the fetus. And this is a chart that demonstrates the mortality that exists. As you can see, the cardiac output going up, reaching roughly around 600 to 650 mils per kilo per minute. The complications for the fetus begin, and mortality is almost universal above 700 or 800 mils per kilo per minute. And this is an example of a fetus who has developed high drops and an in utero demise. So our prenatal risk assessment summarized here. Primarily it anchors around ultrasound measurements of the tumor size, the tumor volume. We use the formula for an ellipsoid, the measurement in 3 dimensions, X, Y, Z, measurements times 0.52 to get the absolute volume for the lesion. We follow that over time. We also look for signs of polyhydramnios, high drops, placental thickness, and then measuring, as you heard before, the tumor-fetal ratio, tumor size to fetal size ratio, and also the growth of the lesion. I'll talk about that in a minute. Echocardiogram is very helpful as an adjunct measure to measure cardiac output. When we looked at growth of the lesion, we found that in the patients that had adverse outcomes compared to the patients who had good outcomes, the tumor volume increased very rapidly in the patients with adverse outcomes and very slowly in the patients with good outcomes. Very logical. When we used receiver operator curves with a cutoff of 61 cubic centimeters per week or 165 cubic centimeters per week, we found a higher rate of adverse outcomes with this cutoff and a higher rate of death at this level. So tracking both the tumor volume ratio and the growth of the lesion can help predict a poor outcome. This is the management algorithm for prenatal care of a baby with SCT. If the fetus is monitored weekly and starts to develop signs of high output cardiac failure, we will give betamethasone in those patients before 26 weeks gestation. We would consider them for in utero debulking. And that's this group here. In utero debulking is not like postnatal surgery. Postnatal surgery is a cancer resection, an en bloc resection of the lesion, ideally. Prenatally, the idea is to debulk the tumor, divide the vascular pedicle, and get out of the OR. So here you can see the fetus exposed through a hysterotomy here in the fetal back. And the first step is to try to delineate the vascular pedicle, thin it out, and then protecting the rectum, obviously. And then using a stapler with simply, either stapler or suture, simply divide the vascular pedicle, remove the exophytic portion, leaving the intrapelvic and the coccyx in place, and then close the incision and put the baby back inside. That's open fetal surgery for hydropic SCT. It's a rare procedure. We don't do it very often. There's been obviously because of the morbidity, there's been a lot of interest in minimally invasive surgery, as you've heard. That surgery can include an RFA, placing the RFA probe directly into the lesion, a laser ablation, either through a direct laser ablation or a interstitial laser, and even sclerosis with alcohol has been done before. As you can see here, for open fetal surgery, the outcomes are mixed. About a 50% to 60% survival overall. This is a meta-analysis, a recent meta-analysis in the literature. Gestational age of delivery, 28 weeks, very early. The tumor size, very large tumors by and large, and almost always patients with high drops and cardiac failure. That's the outcome for open surgery. It's mixed. For percutaneous intervention or minimally invasive surgery, the majority of these patients also have about 50% survivorship as well, and also extreme prematurity as a complication. But the interesting application of this particular intervention has been for very small lesions, lesions that measure roughly 5 centimeters in diameter, lesions that by and large don't typically cause high output failure or even significant morbidity in my experience. If you leave the fetus without any intervention, you can see here even the very large lesions, the outcomes and survival can be good. So the hope for percutaneous intervention exists, and hopefully in the future we'll have better techniques, but right now the results are quite mixed. Next, if the fetus shows signs of high output failure after 26 weeks, this group here in the middle, those are the patients that we'll take down a pathway for early delivery, try to navigate as far as we can before the mother develops mirror syndrome. We'll do steroids and do close monitoring, but those patients will be candidates for early delivery, either via an exit or a cesarean delivery. And here's an example of a fetus that we delivered at 27 weeks. The mother had developed mirror syndrome. You can see this fetus is significantly hydropic. It's a very large solid lesion, lots of areas of necrosis on the outside. You can see in this view here, very large tumor, you can see the obvious high drops. In this baby, we did a delivery at 27 weeks and an immediate resection after a transfusion. This baby did incredibly well. I still receive letters and cards from this family, and this child is now over 20 years old, doing very well. The last group is a group that actually the majority of patients where there is no sign of high output failure, the fetus does quite well, and our typical approach is cesarean delivery at term, 37 or 38 weeks in balance with the maternal risk. And we, after birth, follow obviously the surgical principles, which is in distinction to our prenatal approach, and they're listed here. I'm not going to go over these, but they are always important, complex operations. In the last 6 minutes, I'll talk a little bit about twin reversed arterial perfusion. It's a very odd disease, that's also quite rare. 1% of monochorionic diamniotic pregnancies, 5% of monochorionic monoamniotic pregnancies. It's a situation where there is a normal twin, we call it the pump twin, and another twin who is an acardias, called the perfused twin, who has no head typically or has not a well-developed head, and has not a heart or doesn't have a heart that's functioning well. And as a result, there is reverse perfusion through a single umbilical artery from the pump twin through into the perfused twin. And that's the diagnosis. The diagnosis is obviously the anatomy, but also finding of reversed perfusion through typically a single umbilical artery. Over time, because of that perfusion, the acardias, the perfused twin, will grow over time, and we use two methods to track that growth. They're listed here. One is the Moore method, which is depending on the longest length, measured length of the perfused twin. The other one is using the ellipsoid method as we use for CPAMs, the 3 dimensions here and measuring that. But these are estimates of fetal weight, and we can track this over time, and we can track also cardiac output in the pump twin. And when the size ratio is greater than 0.7 of the pump twin, so perfused twin to pump twin, that's a situation of high risk, and there's a rate of neonatal or in utero demise of roughly 55%. So in this situation, typically is when we consider intervention. We'll follow the patients with biweekly ultrasound typically. If there's any evidence of progressive disease, we'll add an echo and we'll increase the surveillance to once per week. So the options are observation, which is possible in a good number of the patients with monochorionic diamniotic trap. If the echo is normal, there's normal amniotic fluid volume, and the size ratio is less than 0.5, in a monochorionic, diamniotic situation, then observation is probably best. However, if the size ratio increases and goes above 0.5, or we start to see signs of polyhydramnios or high output physiology in the second trimester, those are patients that we would consider for intracorporeal cord ablation or RFA cord ablation with good survival and outcome of the pump twin. Then in the case of a monochorionic, monoamniotic situation, those patients all require cord occlusion, division, and disentanglement because of the entangled cords. Our approach for intracorporeal ablation is typically with an RFA probe like this. I'm sure you have them in your institution. We'll deploy the probe sequentially, but within the fetus to avoid injury. So it's typically within the fetal abdomen or within the fetal liver. And then sequentially turn it on, and it sort of looks like this for a little while until you turn it off. And we'll do that until we have cessation of blood flow in the perfused twin. In the situation of monochorionic, monoamniotic trap, because of the cord entanglement, we'll typically go ahead and do a fetoscopy for cord occlusion, division, and disentanglement. Here you can see the fetoscopy here, the healthy twin, the pump twin, normal nose, mouth. This is the abnormal twin, the perfused twin. This is the mouth of it. It's a very abnormal mouth. Show you the eyes. So very important to confirm which twin is which. That's an abnormal twin. And then we'll find the cord insertion, abdominal cord insertion for that twin, for the perfused twin. I typically use the bipolar for the later gestation ones, and then use the laser to divide the cord after the bipolar. The contact laser, you can see a very nice division. Once that's done, you'll sort of loosen the knot, if you will, in the cord so the cord can unwind and decreasing the risk of a strangulation subsequently. Again, this is only for the situation of a monoamniotic trap. So in summary, there are significant risks for preterm delivery and in-utero demise related to high cardiac failure in both TRAP and SCT. The outcomes can be predicted quite well with surveillance, close surveillance Dopplers, tumor fetal ratio, size ratio, and an estimate of the solid tumor growth. The options for treatment of impending demise include early delivery or fetal surgical debulking or cord occlusion, division, and RFA for the situation of TRAP. Future strategies for fetal SCT and for TRAP are going to rely on advancements in minimally invasive surgery and something I think you also are using here, HIFU, high intensity focused ultrasound. Hopefully next year or the year after I can give you an update in that area. Thank you very much. Happy to answer any questions at the end of the talks.
Thank you, Professor Ayman, for this nice presentation. Our next speaker is Dr. Shurabi Nanda. We're going to speak about how to prevent stillbirth in twin pregnancy.
Thank you. Thank you for the invite. So we talk a lot about multiple pregnancies. So I decided to start talking about how do you... I decided to talk about how to prevent stillbirths and how to actually offer care for women in multiple pregnancy. Some of the numbers are UK based, so I don't expect you to have the same numbers in Egypt. But in the UK, although with single embryo transfer, the number of, the aim was to reduce the amount of multiple pregnancies, but as you can see here, the age of the parents is on the rise, and as a result of which, you will have more multiple pregnancies because dichorionic twins are higher in advanced age, as well as the increased chance of IVFs. So we know the complications of multiple pregnancies. We're not going to repeat those, the maternal and fetal complications. And these are some very nice resources for the parents, for the patients, if you wish to give them those. But actually, let's go to the granularity. 2 in 64 pregnancies are twins. Twins have got about 2.5 times the risk of stillbirth and 4.5 times the risk of neonatal death. And these are certain numbers, and I'm trying to work out how the pointer works. But these are certain numbers that you can see over the years in the UK. And actually, yes, there's a slight decline in the stillbirth rate. But actually, despite having some good evidence in place, good guidance in place, the numbers are not what we would expect them to be. The result is the stillbirth and neonatal deaths are increasing in multiple pregnancies, whereas the gap is reducing in singletons. So we're not doing something right. And that led us to start to work together with the third sector organizations like the Twins Trust, who looked at whether if there were certain things that we can change in the way we deliver care in twins, whether that can lead to a reduction in in the stillbirths. So here you are. If you have, by the NICE quality standards, so if you have, say, for example, a designated sonographer, or in your case, an obstetrician who will be doing scans for twins, you've got an MDT who will look after, so a clinic who will look after multiple pregnancies, you do serial growth scans, you talk to them about preterm labor, you talk to them about delivery planning by 32 weeks, you have a team with an obstetrician who is taking accountability for these women, and you make, when you do the scans, you do systematic labeling. So this is what we call as quality standards 46 of the of the NICE guidance. If you enable all of that, yes, there's the cost and benefit ratio, but actually, in this work that Twins Trust did with the NICE works, they found that you can reduce the number of emergency admissions to the neonatal unit by 1,000, and you can reduce the amount of cesarean sections, so you can save the NHS 8 million. So actually, that 8 million could have been used to invest into the proper infrastructure framework. How do you translate that? Why do these stillbirths happen? Forget the congenital abnormalities, forget the lasers that we do for you know, the things that are inevitable. We worked with Embrace to actually work on this confidential inquiry, which was published in 2021. And we looked at, in that year, we looked at all the stillbirths in multiple pregnancies with a panel of experts to see whether there's any learning that we can have. We found that nearly half of the babies and nearly 2/3 of the mothers, if we could make any change in the way we delivered care, we would have made an improvement in the outcomes. And that included both deaths or single twin deaths. So moving forward, what are the kinds of deaths? So these are two tables which show poor care in the areas. If you look at the twins, the poorest of the cares was in the antenatal period, the labor and birth, and neonatal period. In the mother, look at that number. The majority of mums, 3/4 of mums had poor care in the postnatal and the follow-up and review. But this talk is not for the mother, this talk is for the baby. So these are some vignettes that I've taken from the inquiry, and you may be able to relate to this. So this is a sonographer who was a locum sonographer in a unit. It's a real-time scenario. They mislabeled the twins as MCMA. They relabeled the twins as MCMA at 16 weeks. Is that the right thing to do? Well, the reason I'm using it here is probably not the right thing, but that is because there was a missed opportunity to detect twin-to-twin transfusion. And when she came for her anomaly scan, there was demise of both the babies. This is another scenario from the inquiry. The sonographer were scanning for twins, dichorionic twins with discordant growth, and subsequent scans by 32 weeks, you can see that the discordance is minimal. And when she presents, there's an abnormal, because of an abnormal CTG, there's been an IUD of 1 twin for a while ago. So the sonographer has been measuring the same baby twice. And these are real-time UK scenarios. So moving forward, do these cases cause litigations? Yes, they do. So this is some old data from CNST, which is our obstetric negligence scheme. And you can see that whereas obstetrics and gynecology is only 1/5 of the total claims, nearly half of the money goes for obs and gynae claims. And in that, you have this antenatal care, which figures 50% of the antenatal investigation claims were because of bad scanning. So I'm going on and on about scanning because when it is multiple pregnancy, you have to follow a certain protocol, which is this for monochorionic twins and this for dichorionic twins. And with serial scanning, systematic labeling, using of the growth charts, you will be able to prevent some of the disasters. In the confidential inquiry, we found that 1 in 5 babies, mothers did not have scans per schedule, 1 in 6 did not have any systematic labeling, and about half of them did not have either the charts for twin growths or they did not have discordance measured. Now, I'm not going to go into the specific twin charts or the non-specific twin charts because that's not the remit of this talk. The importance is you use a chart and you plot the baby's growth along it and keep it similar. This is a patient who was her first pregnancy. She was in induction of labor at 38 weeks and there was difficulty in monitoring. Is the CTG normal? Do you use CTGs? Most of the twins would go into, would have cesarean section, but this was a lady who was going to have an induction of labor. There was a significant loss of contact, and every time the sonographer went, the doctor went and they tried to reposition the probe. By the time they could not get any fetal heart, which is towards the end here. You can see both, there was a posterior uterine rupture, both the babies were in the abdominal cavity, and the babies have got quadriplegic cerebral palsy. So, coming to intrapartum care, if you go to Google and put negligence claims for intrapartum management of twin pregnancies, the majority of the stillbirths, majority of the claims are because of the aftercoming head or because of the delivery of the second twin. To the extent that the largest claim in the history of UK, which is 38 million, was a case of locked twins. So after antenatal care and ultrasound scan, the other place where you really need to work on is if your women are going to go for a vaginal birth and watch them like a hawk. Resuscitation. So the third area where they needed improvement was resuscitation, but our talk is to prevent stillbirths. This is only a case, you can read it, but this is only a case to illustrate that there has to be planning. When you have one of the things that you need to talk about in twins is preterm labor. By 16 weeks, talk to them about the risk of preterm labor. By 24 weeks, tell them that there's a, that there's a high risk of preterm labor. And if there is preterm labor, listen to what the extent of resuscitation can be provided. So these parents did not want resuscitation of 23-week severely IUGR TTTS babies, but the babies were then born, and then the babies spent so many days in the neonatal unit with multi-organ failure. So this is a very nice piece of resource. This is from BAPM. You can take a picture if you want. And this is for singletons. But actually, I use this to counsel our women about individual gestations. What is the chance of your babies being able to survive? Because it is important for them to know. So coming back to the maternity engagement program, for the, which was to improve care and improve the adherence of quality standard 46 of the NHS, of the NICE, so that you can reduce the chances of disparity in care. If there were certain recommendations that were introduced in a unit, you audit the unit again. So for example, like I said to you, introducing a specific team, introducing a designated sonographer. So the ones that I've highlighted, if you label the babies by 14 weeks, offer them specialized multidisciplinary care, see a midwife, there's a care plan, women know about the monitoring about fetal complications. Care is provided by the same person or the same team that is equipped to offer that care, and then you've discussed preterm labor and mode of delivery. If you do these basic things, then you are able to reduce the chances of stillbirth, neonatal admissions, emergency sections, and neonatal deaths. And this is real life data from units that have been audited and then re-audited after the introduction of recommendations. So what happens when they die, when babies die? We have to learn from those lessons as well. And that every unit has got a specific thing in place. This is called Perinatal Mortality Review Tool. And this is to highlight that if there is any demise, then in the recommendation in the United Kingdom is to review them within 72 hours, case within 72 hours, have a panel of experts, ideally an external person as well, learn from there, find out causes, what didn't go right, and make those recommendations for change and involve the parents, feed back to the parents. And of course, it may change once the postmortem comes back or the histology comes back. That's the, so just to summarize things, we know that mothers with multiples get a lot of scanning, get a lot of care, more than what a singleton mother would do. But then this was some work that was done by the National Perinatal Epidemiology Unit in Oxford, and they found that mothers actually don't have a good experience when they have twins compared to singletons. And then this is just hot off the press. This is a report called the State of Nation report, which tells us that United Kingdom, where I come from, or where I work, is one of the most expensive places in Europe or EEA to deliver babies with twins. It's 20,000 more expensive. And nearly 85% of families, either one parent or both parents suffer from perinatal mental health issues, and that can be up to 3 years of age. So when we know this for already babies that are born with, families that are born with two children that are born alive, can you imagine what the outcome would be if one baby was dead? And that is the reason why, and that was the sole purpose of this talk. If we have right resources, so this is a compendium of all the common go-to places where you can look at all the resources. You have good teamwork, and you understand where the parents are coming from and where you are, what kind of care you can offer, the capability of the unit that you're offering care. For example, mothers in preterm labor, you do not have tertiary neonatal facilities, arrange a transfer to a unit where they can, then you will be able to achieve. This was our woman with the, this is with consent. This is our selective growth restriction TAPS babies, and this is them at 6 months of age. Thank you very much.
Thank you, Professor Surabi. Thank you. Then our next speaker is Dr. Mahmoud Yahya about fetal abdominal cysts.
Thank you, Dr. Layla. I know that everyone wants to go home now, yeah? So we'll be quick. So we're going to talk today about fetal abdominal cysts. It is something that we see quite frequently in scans. So let's go straight into cases. So this patient was referred to us at 28 weeks. She has a balanced translocation, 10-15, low-risk trisomies otherwise by screening. They referred her from the scan department because some polyhydramnios and an abdominal cyst. And this was the scan finding. I think it's a spot diagnosis. Everyone here would be able to most probably identify what is this. So we found polyhydramnios. It's slightly abnormal profile, but nothing major. And obviously you can see the typical appearance of duodenal atresia. You can see here the duodenal cap and the distended stomach. We looked at the brain as well, and we found that the cerebellum is a little bit small, but the rest of the brain anatomy looks normal. So we said that's a duodenal atresia. There is a small cerebellum. There is a mild retrogradnia and polyhydramnios. We explained 30–40% of those babies will have a chromosome problems, and the outcome will be really dependent on the brain development and the genotype. The couple wanted an amniocentesis. We did an amniocentesis, and the baby has an unbalanced translocation, obviously inherited from the mother. Seen by genetics, they counseled about intellectual abilities, and they said obviously this baby is likely to have some sort of long-term neurodevelopmental delay. So at this point we offered whether we continue the pregnancy or terminate the pregnancy. The couple wanted to carry on with the pregnancy, and as part of routine we offer fetal echo for all patients who has significant anomalies. And we did a fetal echo later, and there was a hypoplastic arch which confirmed coarctation of the aorta later. So the outcome of this baby, delivered by cesarean section at 37, duodenal atresia, had surgery 2 days after birth, and confirmed coarctation, waiting for surgery. Next case, this was a lady in her second pregnancy, low risk trisomies as well. Again, found an anomaly cyst, an anomaly in the a cyst in the anomaly scan, which was an incidental finding, referred to us. As you can see here, this is the baby's bladder, and behind the bladder there was a small cyst. And in the sagittal views, you can see here, this is the cyst, here sitting in the front of the spine. And you can see clearly it's separate from the kidney, separate from the bladder. Because the cyst lies within the rectal area, so we checked the gender, it's a female, and we checked actually the external anal sphincter, as you can see, which we call a target sign. And you can see clearly there is a target sign here, so it was a little bit confusing. We thought it's an anal atresia, but it doesn't really make sense because we can still see the external anal sphincter. We continue to examine the baby, and the baby actually does have a VSD, as you can see here, and an overriding aorta. So we said the baby was small as well, so we said that's a VSD with aortic override, that's a small baby, single umbilical artery, and we said possible anal atresia. It doesn't really match the diagnosis, but we said we will follow this baby up, and we offered amniocentesis. The couple didn't want, explained the outcome will depend really on the genotype, because we're not sure what's happening here. We said the outcome might be favorable if this baby doesn't have any chromosomal genetic condition, and obviously we said there is a possible surgery that will be needed in early childhood and long-term bowel problems. As you can see, towards the end of pregnancy, the rectum and the sigmoid was quite distended, and this baby was delivered by cesarean section, has a VSD and aortic override, and actually this was an anorectal fistula, and that's why you can see still an intact or the external anal sphincter was fine, so it was not an imperforate anus. Case number 3, 31 weeks, incidental finding of an abdominal cyst, low-risk pregnancy and low-risk trisomies. Anomaly scan actually was fine. And this lady was referred late in pregnancy. You can see here, there is a cyst sitting beside the bladder, clear, separate from the kidney and separate from the bladder. This was a female fetus, and as you can see here, this is the cyst, this is the stomach, this is the kidney, this is the bladder, this is bowel. So the cyst is clear and separate from all the organs around. This was an ovarian cyst, and after delivery, the cyst was managed conservatively and did not require surgery. You can see this is the cyst here, this is a postnatal scan. So what are the possible cysts? How we do approach cysts in pregnancy? So once you find an abdominal pelvic cyst, you have to ask the question, is it an organ or it's not an organ? If it's an organ, is it in a normal position or actually it's outside where it should be? If it's normal position, then ask yourself, is it a good size or it's big, or does it have any special features? Does it have peristalsis? Is it hyperperistaltic? Does it have any specific features? And if it's not an organ, then what is the relation to other organs and where the blood supply is coming from, if there is any? So that's an example. If you see a stomach, is this stomach sitting in abnormal position? And if that's the case, then you think about heterotaxy syndromes or diaphragmatic hernia. If it's a large stomach, then you think about pyloric atresia. If there is double bowel, as we can see, you think about duodenal atresia. Pyloric atresia is very difficult to diagnose anyway, and it's not by definition an antenatal diagnosis. If you see kidneys, then is it large or it's in abnormal position? Abnormal position, it might be an ectopic kidney. It's not unusual to find ectopic kidneys has dilated pelvis, so it might be easily diagnosed as a pelvic cyst. If it's a large kidney, then or large cyst in the kidney, are they communicating together or non-communicating together? If they are communicating, then you think about hydronephrosis, hydroureter, or duplex kidney. If it's not communicating, then you think about the multicystic kidney or the simple renal cysts. Then if you have a urogenital organ, is it, the first question, is it bladder or not bladder? The easiest is just to think about the bladder and check the bladder first. If it's a bladder, then is this cyst inside the bladder? Then it might be a erythrocoel. Or it's a large bladder, then it's a lower urinary tract obstruction. Or if it's not a bladder, then it might be a cloacal anomaly. Is it a vagina? Or it's an ovarian cyst, especially in a female fetus. If it's a hepatobiliary or a GIT, then if liver or gallbladder, you can have a choledochal cyst or hepatic cyst. If it's bowel, then a small bowel will usually cause a lot of small loops that are packed together. If it's a single loop, it's more likely to be large bowel. In obstruction, we always see a lot of peristalsis, and we can see polyhydramnios if it's high bowel obstruction. It's very unlikely we see polyhydramnios in the large bowel or the anus or imperforate anus or anal atresia. You can see other cysts actually. You can see, as discussed in the previous presentation, you can see an enteric duplication cyst, mesenteric cyst, meconium pseudocyst, urinoma. But actually, you can see a cyst that's not a cyst. It's actually a vascular malformation, and that's why it's very important, as we will say now, to check the color Doppler in any cyst. Quickly now, what do you think this is? If I tell you this is a kidney, that's another kidney, that's a bladder, what would you say this is? These are cysts that are not communicating, filling the kidney. So that's a typical or spot diagnosis of multicystic dysplastic kidney. What about this one? So that's a kidney there, that's a cyst there. You can see there is no vascularity, the bowel is there. And if I tell you that's a female fetus, what would you say? Another ovarian cyst, and that's actually the postnatal scan. You have to know that postnatal, the ovarian cyst can have bleeding. That's a bleeding inside an ovarian cyst, which can happen, and it's usually resolved spontaneously in majority of cases. And that's a patient that was an interesting patient actually sent to us because of possible situs inversus. As you can see here, there was a cystic structure here, and it was on the right side of the baby, so they thought that's a stomach, and they sent the baby as a situs inversus. But actually, we found the stomach on the left, and we looked at the kidneys, they were normal, and actually this is a right-sided renal cyst, which disappeared spontaneously, actually, during pregnancy later. What about this one? So that is a bladder here, and inside the bladder you can see this small structure here or a small cyst here. That's a erythrocoel, and typically it will be associated with other renal anomalies. What about this one? So that's a cyst at the lower pelvis of the baby. As you can see here, this is bladder, this is bowel, stomach. What do you think this is? And this is the baby's cord. Initially it was referred as a cyst in the cord, but actually this was a penile urethra. So that's actually a dilated penile urethra in a male baby. What about this one? So that's a small cyst sitting inside the bowel area. There is a liver here. Would you say this is a simple cyst just in the liver? This was the initial diagnosis when she was sent. But actually you put color Doppler, and actually that's a varix. That's actually a varix into the umbilical vein. So always use color Doppler. So an abdominal cyst, you want to check the site, you want to check the size, you want to check the Reichel volume in relation to other organs, and also the movement, because if it's attached to an organ, it will move with this organ. It might give you a clue. You look for special features. Is this bowel hyperperistaltic, so is it obstructed or not? And always put color Doppler, because it will give you an idea about where the supply is coming from, or actually whether this is a vascular organ. The management usually for majority of ovarian cysts are conservative, but we offer them all invasive testing in majority of cases. You have to rule out other anomalies because they will be associated with other anomalies, especially cardiac anomalies. follow up the progression and follow up the amniotic fluid volume. Can we do an intervention in cysts? Very rarely, but yes, you can, if obviously it's causing obstruction or if it's causing obviously pressure on other organs. And it's very important to reach a provisional diagnosis in those cases to plan delivery, whether those patients can deliver in a local unit or they will need surgery immediately after birth. So that's very crucial for those babies because actually it can heavily impact survival. And obviously you counsel them about surgery and prognosis. 30 to 50% of antenatally detected cysts will actually disappear. But there's up to 75% of them, if they persist, they will require surgery after birth. Majority of pelvic cysts are actually ovarian, and intestinal cysts will almost invariably need some sort of surgery after birth. Thank you very much.
Thank you, Dr. Mahmoud. Really interesting presentation. Now we came to the end of our session. Any questions? Any questions from the audience? Any questions? Thank you.
Okay, so I will ask the questions then. First question for Dr. Guinée. You presented a very nice summary of exit procedures for obstructed airways, tumors, and such. There is a trend I see developing for the diagnostic fetoscopy being done in situations where airway obstruction isn't 100% confirmed. This being done as in lieu of just proceeding with an exit procedure. So fetoscopy with laryngoscopy, and some investigators have actually placed an endotracheal tube fetoscopically, and then in that case proceeded with a C-section rather than an exit procedure to reduce morbidity. Just wondering about your thoughts on that type of thing.
I think it's the way to go. We didn't have the chance to go this way. I know that some groups are starting to offer this alternative, but I think it's the way to go. Why not? If you can see and at the same time offer something to release the obstruction, it's wonderful.
So I'll just extend that question, please. I'll extend that question. So it's now going to the diagnosis bit. Do you tend to offer them a third trimester fetal MRI before, in our unit, we've got a low threshold to offer fetal as well as whole body MRIs. Do you tend to offer that to decide whether you would need for the suitability of exit or for the suitability of in utero debulking?
We always, I don't know if I understood Ben good the question because I can hear it properly, but we always perform an MRI in every single malformation that we are going to offer something. This far, I will say that the bulking procedures in our hands is once every 5 years. So my opinion on that, it's not really relevant, I think. If you have to.
No, I agree 100%. The debulking procedures are extremely rare. We don't do them very often. As a matter of fact, it's been almost a decade since I did one. But the third trimester scans are routine. Patients with sacrococcygeal teratoma, we will routinely perform a third trimester MRI. For a variety of reasons, anatomy being the primary reason. And also we can detect with enough resolution, extension, well, not the feeding vessel, but also the extension into the epidural space, which you can see from time to time. And when I have a good quality third trimester scan, I do not get a postnatal scan. I'll just take the child to the operating room based upon the prenatal imaging in the third trimester. So it's safer rather than sending a child, a newborn, to an MRI scanner where it's very cold. As a newborn, very often premature, we'll do a third trimester scan. Yeah, couldn't agree with you more. And one question for Dr. Mahmoud. When we have patients with ovarian cysts, We are relatively aggressive with cyst aspiration. When the cyst diameter exceeds 5 centimeters, our counseling is that the rate of ovarian preservation is better when they reach that, and there's some prospective data about 5 years ago to support that. And then it also, we know that the risk of asynchronous sequential ovarian torsion of the other side is about 5 to 10%. So I think it's a very important thing for ovarian preservation and for the few patients that may be, unfortunately, with a bilateral torsion before puberty, which is a disaster. So this is how we counsel, and I'll even sometimes, in rare cases, do another aspiration because it comes back. I wonder, how do you counsel in the UK?
Thank you, Dr. Ayman. I think that's a very good point, actually. The thing is, we do counsel them actually. So when I see patients, obviously with the ovarian cyst, we tell them that there is a possibility, especially with cysts larger than 5 centimeters, that there is risk of torsion and there is risk of losing this ovary. Actually, this is part of the counseling. We don't offer them intervention in the UK. Unfortunately, it's not one of the standard procedures we do. Even though we know that there is a possibility of losing this ovary, but it's not a standard procedure to offer them drainage, actually. So majority of cysts that the ovarian cyst actually will be discovered, majority of them will be discovered in the 3rd trimester anyway. Majority of them will be picked up late in pregnancy anyway. So they tend not to resolve in pregnancy because by definition they have, yeah.
Later on, after how
yes, we follow them up for after delivery. We follow them up until the cyst completely disappears. So they will go to a special surgical pediatric clinic and they will have follow up until the cyst disappears completely or proceed to surgery. Both of cysts resolved completely. One disappeared completely after 1 year, and the other one, I can't remember, I think about 6 months. So I have a couple of questions as well to Dr. Ayman. You mentioned beautifully about obviously the TRAP sequence and the intervention. How would you choose between the radiofrequency ablation and the cord coagulation for those patients?
Thank you. The question about the means in which we achieve cord ablation, whether it's with the RFA probe or a bipolar probe. Honestly, it's about the technical approach and what's safest, what's easiest. I think both are excellent techniques. The advantage of the RFA, it's a 17 gauge needle. You can do it in early gestation with an extremely low rate of PPROM as a result. So if the fetus is presenting itself in an anterior way in an early gestation, our intracorporeal RFA is an excellent technique. Again, these are all diamniotic situations, mono-di. The bipolar I will use even in a mono-di situation if the approach is favorable and there's fluid around and I can actually see the cord and grasp it. In a little bit later gestation, I believe the bipolar forceps is a better approach in that situation. In the monoamniotic situation, it is always about cord division, and that cord division can either be done with one port before 22 weeks or 21 weeks, just simply placing the laser and lasering across very carefully across the cord insertion at the umbilicus, or later gestation when the cord is very big and sometimes the space is very limited. I'll put a second port in, a 7 French port, to be able to put a grasper in and do the bipolar, a scope, and then a laser division. So depends on the technical approach, but I think the forceps is an excellent approach. Oh, outcomes are excellent. Outcomes are excellent. For RFA, for 95% of the patients with TRAP that have an RFA, greater than 95% of the pump twin survives, and they're excellent. We have a very small number of the monoamniotic cord division, but we have very good outcomes. We actually recently published those outcomes in the White Journal. But yeah, outcomes are excellent.
So the other option is also intrafetal laser for first trimester traps. We know that there's a natural attrition from first trimester to second trimester, so you may want to wait and then of RFA or cord occlusion. But if you use a CVS needle and use intrafetal laser into the trap sequence right in the early first trimesters, that also has good outcome.
Final question to Dr. Strabi. You spoke about twins, obviously, and counseling regarding the outcome and complications. So when you sit with a pregnant lady with twins, especially the monochorionic, and you tell them about, obviously, all the risks during birth, especially risk of C-section for the second twin, risk of perinatal mortality, and risk of acute twin-twin transfusion, all these kind of things, how would you convince them to go for normal delivery? This is the question.
So we live in an era of choice. So I'm not there to convince them to do anything. I would give them the numbers that are out there. I quote the NICE guidance, but I also quote the twin birth study, which is the biggest study that we have on intrapartum management of twins. So I say that if you have an induction of labor, there's a 40% chance, 40 to 50% chance, depending on whether she's a multip or a primip, that you will end up in a cesarean section. For if you did deliver the first baby vaginally, then there's a 5 to 7% chance of a C-section for your second twin. And then, of course, there's the theoretical risk of acute twin-to-twin transfusion, which we will not be able to quantify. This is like literally the standard spiel that I have. For mothers who've had previous VBACs, who've got any other complications in monochorionic twins, I wouldn't offer them a vaginal birth. And also post-laser mums, I wouldn't offer them. And of course, this is only if the leading twin is cephalic.
Thank you very much. Any questions? Thank you, and we came to the end of our session. Thank you.